In this lecture, we're going to be talking about managing hematological problems. And we're going to keep it somewhat basic as far as the PowerPoint goes, as far as addressing anemia, because a lot of the symptoms are going to be the same, but there's lots of different forms and causes of anemia. And you're going to still need to know those different types of anemia because they are treated differently. And I did create a table that you guys can use to sort of help organize your studying and which blood disorders you should really be aware of. There's several organs that are involved in producing blood products, whether that's platelets, plasma, red blood cells, and they are all listed here, so you can take some time here and look at all this and make sure that you understand what organ and what their function is. So again, I posted a table on all the blood disorders you should be aware of. You can use that as you read the chapter and sort of fill it out. It will be a really good study guide, so it will be very beneficial for you guys to use it and essentially stay organized while you're reading all the different blood products. So anemia is not a specific disease, it's more of a manifestation of a pathological process. There's several different groups of anemia and causes of anemia, and it can range from the morphology of this red blood cells or an underlying cause, whether it's autoimmune, genetics, some type of virus, or drugs that are causing anemia to occur. Anemia is lower than normal hemoglobin and fewer than normal circulating erythrocytes. And that's a sign of an underlying disorder. And there's several different types of anemias. There's the hypoproliferative, which is a defect in the production of red blood cells. This can be caused by iron deficiency, vitamin B12, folate deficiency, also decreased erythropoietin production. Cancer can also cause production of red blood cells to be diminished. On the other side, there's also disorders that cause hemolytic or hemolysis of the red blood cells, so excess destruction of red blood cells. So we'll be covering a little bit of everything. The table, again, that I posted will have all the ones that you should be aware of. Manifestations. A lot of the manifestations come from the patient being hypoxic or essentially low hemoglobin because the decrease in red blood cells, there will be a decrease in oxygen carrying or oxygen availability because there's not enough red blood cells to carry the oxygen needed. And so that can cause fatigue, weakness, pallor, jaundice. Jaundice can occur with the destruction of red blood cells, so you're going to have the increase in serum bilirubin when those red blood cells are destroyed. You can have some tongue color changes, nail bed changes, and so most of the manifestations, though, again, will just come from the fact that there's not enough oxygen readily available from the red blood cells, and that's going to exacerbate the symptoms. So just going a little more in depth, so anemia, so from the pallor symptom or manifestation, it's due from the decreased oxygen or hemoglobin and decreased blood flow to that skin, which is going to cause the color change. Jaundice with increase in the concentration of the serum bilirubin from the destruction of red blood cells. Pruritus, which can be caused by the increase in the bile salt concentration in the serum and the skin, again from the destruction of the red blood cells. Cardiopulmonary manifestations can be exacerbated from the lack of cardiac output if its anemia is from a hypovolemia, or if it's more of an O2 or oxygen demand with the lungs or cardiac, you can have chest pain, shortness of breath, as well, weakness and tired and fatigue, essentially manifest with patients that have anemia. There's sort of different levels of anemia. Mild, hemoglobin from 10 to 14. Also remember that males and females both have sort of a different range for their normal hemoglobin level, but mild hemoglobin from 10 to 14 normally exist without symptoms. Possible symptoms could be essentially palpitation or dyspnea, definitely with exertion. But if the patient's at rest, they'll normally be asymptomatic. Moderate hemoglobin, so anything between 6 and 10, you can definitely have some increase in cardiopulmonary symptoms. Experienced at rest and definitely during activity. And that's where you're going to start getting the shortness of breath. You could have chest pain if there's not enough oxygen getting to the heart, fatigue, dizziness, weakness. So you're going to get all of these sort of vague symptoms when a patient starts having more of a moderate anemia. In severe anemia, you're going to start affecting all the different organs or systems in the body, pulmonary, neuro, GI, your mouth, skin. Everything that requires oxygen is going to be affected. In the hospital, we normally do not transfuse a patient if their hemoglobin level is above 7. So anything under 7, we will transfuse a unit of blood. However, if the patient is symptomatic with a hemoglobin level of 7.5 or even 8, then we're going to go ahead and transfuse because they're symptomatic, and that means that their body's not able to compensate for the fluid loss. For diagnostic testing, it's going to be focused on trying to find the cause of the anemia. So if it's a vitamin B12 or folate deficiency or an iron deficiency, then we can see that in the lab results. It could be the erythropoietin levels, which helps essentially stimulate red blood cell production. And we'll get to that in the next slide. And then there's also the bone marrow aspiration. So we can do a bone marrow aspiration and essentially evaluate the bone marrow to see if there's the correct level of essentially immature red blood cells, making sure that the bone marrow is producing the red blood cells appropriately. And then we can essentially determine whether this is a bone marrow, a production issue of red blood cells, or are the red blood cells being destroyed after they are produced by the bone marrow. So there are a lot of different diagnostic tests that we can do and run to determine the cause of the anemia. So here we have erythrocyte production. So erythropoietin, or EPO, is a glycoprotein primarily produced in the kidneys. It helps increase the number of stem cells committed to RBC production. So essentially it helps ramp up production of RBCs. Because this glycoprotein is primarily produced in the kidneys, patients that have kidney failure or chronic kidney disease and are on dialysis, their kidneys do not produce this, and so that's where a lot of the times these patients end up anemic, is because of the erythropoietin production is not there. And also the patients that are on dialysis, the dialysis filter can also cause some hemolysis of the red blood cells. And so these patients that are chronically on dialysis, at least once a week, you could potentially be giving an injection of epoetin, which is a synthetic form of the erythropoietin. And essentially, the EPO shot will help in the production of red blood cells for these patients that have kidney failure. So again, decreased erythrocyte production. You will have decrease in hemoglobin synthesis, defective DNA synthesis, and red blood cells. So the red blood cells will not, if the DNA is defective, the red blood cells will not last as long. The typical lifespan is about 120 days. And it also will not be able to carry oxygen appropriately. And you will also have the diminished availability of erythrocyte precursors with the decrease in erythrocyte production. Medical management of anemia, you're going to want to correct or control the cause. We can transfuse blood products as needed, but we're also going to want to go over dietary therapy, making sure that they're taking in enough iron and vitamins, and also, again, sort of determine the cause of the anemia if it's an autoimmune disorder, then having them on some type of immunosuppressive therapy can also help prevent the destruction of red blood cells. Assessing patients with anemia, we want to definitely make sure we get a detailed health history, definitely a family history, because sometimes a lot of these anemias are genetic and they run in the family. And we want to make sure that we're getting as detailed as possible with that. Laboratory data, that will help essentially diagnose and determine what type of anemia it is. Doing a nutritional assessment. Again, medications can sometimes induce an anemia. Definitely the coags, the anti-coag medications. We're also going to want to assess the patient's potential for GI loss or GI bleeding, making sure they're paying attention to their color of the stool, whether it's a dark or like a black tarry stool. We also, some females have heavy menstrual cycles that can also cause anemia as well. Definitely if they already have some type of iron deficiency. And so we want to, again, sort of get as detailed as possible with the history on these patients so we can determine that cause. So planning for these patients, the major goal would be to decrease fatigue, making sure that they can essentially perform their ADLs. We do that by maintaining the adequate nutrition, making sure they're taking in the appropriate vitamins, minerals, and also maintaining adequate tissue perfusion, which monitoring blood pressure and heart rate and your oxygen level, and then making sure that they're compliant with the prescribed therapy and absent of any complications. So interventions, we're going to want to perform physical activity while maintaining adequate nutrition and perfusion, monitoring blood pressure, heart rate, vitals. And also, we're going to want to cluster our care with these patients because they can get fatigued easily, definitely with physical activity. Different diagnoses for anemia. You can have activity intolerance, imbalanced nutrition, ineffective therapeutic regimen management. You can also have imbalance as far as risk of fall because of the risk for the patient getting weak, dizzy. Definitely if there's some hypovolemia occurring in their blood pressure, they can become hypotensive when they stand up, so they can have some orthostatics that can cause issues as well. And so our goals, again, will really assume and make sure the patient has a normal activities of daily living, maintaining adequate nutrition, and developing no complications related to anemia. And this is, again, sort of just a little summary page, making sure that we also provide the specific drug therapy, oxygen, and a lot of teaching for these patients. The older population, as they develop chronic diseases, that can also lead to certain types of anemia. They are also at risk of nutritional deficits, so iron, vitamin B12, and folate. And so we want to, again, make sure that we're doing that health history on them, and so we can help sort of determine the cause of this anemia, and making sure that we are assisting them and providing that care so we can help them manage any of the symptoms that they're having. So along with anemia, you can have potential bleeding disorders that cause the anemia, and medications can induce this. Genetics can also cause bleeding disorders. We're going to focus primarily on heparin being a medication that can induce bleeding disorder, and then a syndrome called DIC, which is a life-threatening syndrome that it can occur from a variety of factors. Well, we'll be covering that in just a second. So pharmacology and coags, fractionated heparin. Essentially, heparin helps thrombus prevention. However, it can also cause what's called heparin-induced thrombocytopenia, and that's when there's a reduction in the platelets. And so platelet value levels drop significantly when patients are started on heparin. There's a panel that we can run when the patients have what we believe to be heparin-induced thrombocytopenia, or also abbreviated HIT, HIT, to determine that that is the actual cause of the thrombocytopenia. And if it is, then typically just stopping the heparin and switching to a different anticoagulant, or maybe just pausing the anticoagulant for a little bit, will bring the platelet levels back up. Warfarin or Coumadin also is a blood thinner. We measure the effectiveness through the INR. It impacts the vitamin K. There's also the newer drugs that are out on the market, the Pradaxa, Xarelto, Eliquis. All these have different effects. They're all blood thinners, but they all affect the coags differently. And some of them do not have reversal agents, and so we really need to be careful when these patients are on these meds, that we are paying attention for potential bleeding issues. Again, thrombocytopenia is when there's a reduction of platelets below 150,000. There can be immune thrombocytopenia, so essentially an abnormal destruction of circulating platelets, some type of autoimmune disorder. A lot of times these patients are asymptomatic. However, they could potentially come into a doctor's office with increased bruising or stating that they bruise easily. They also might have some petechiae forming on the extremities, and so that could potentially lead the doctor to investigate the possibility for thrombocytopenia. There are sort of different types of thrombocytopenia. I sort of already talked about heparin-induced thrombocytopenia. You also have the idiopathic, thrombotic form as well. And so, there are different tests that we can run. That's called the HIT panel that we can run that measures different levels of the heparin and the coags that it affects, and so we can determine, essentially the exact cause of the thrombocytopenia. There's other essentially acquired coagulation disorders. One common one is the liver disease. As you remember from previous blocks or even anatomy, the liver plays a huge factor in coagulation. It produces almost all the coags in the body, and so and all the clotting factors. And so if the liver is not functioning properly, then the patient's not going to be able to have the appropriate level of clotting factors in circulation, and so they will have some type of coagulation disorder. Vitamin K deficiency can also lead to this as well, along with some also autoimmune sort of diseases. The other one, though, the one that I spoke about earlier, the disseminated intravascular coagulation, so DIC, is a life-threatening condition, and that we need to be sort of aware of and treat appropriately to prevent essentially the patient from bleeding out and ultimately death. So DIC is not a disease, but it's a sign of an underlying disorder. It's triggered by several different factors. It could be sepsis, trauma, shock, cancer. Patients, pregnant women can also, during pregnancy, or actually delivering of the baby, can actually go into DIC. Allergic reactions can also cause DIC from occurring. Its altered hemostasis mechanism causes massive clotting in the microcirculation, and as clotting factors are consumed, bleeding then occurs. So on top of clots forming and causing essentially many areas of ischemia, you're going to then cause bleeding. And so it's, again, very life-threatening. We need to act fast when the patients do enter into DIC. There is a DIC panel that we can run for as far as a laboratory test to determine that they are in DIC. And so we're going to want to treat the underlying cause, correct tissue ischemia. We're going to want to give fluids, maintaining that blood pressure. We're going to replace coag factors. And back in the day, we used to use actually heparin to sort of help reverse DIC, or not really necessarily reverse, but slow it down. And you're probably wondering, doesn't heparin cause bleeding? And yes, it does, because it is an anti-coag. However, it does prevent clots from forming. And so that is the initial phase of DIC, is the clotting factors being consumed. So if we give heparin, then that can actually slow down and minimize thrombus formation, which causes ischemic events in the tissue, which then leads to bleeding in that area, because the microvascular system essentially then starts leaking out in that ischemic area, resulting in more bleeding. And so if we can actually minimize those clot formation, then we can minimize some of the damage that's done by DIC. However, now with all the synthetic coag factors that we can make, and also administering platelets and fresh frozen plasma, we do not really use heparin at all anymore for DIC, but you could maybe see it being used in a rural area that might not have access to all of the essentially clotting factors that we can give patients now. So the pathophysiology of DIC, again, starts with the significant illness. On the left side, you have the initial phase of the impaired fibrolysis and thrombus formation in microcirculation, which then leads to the consumption of platelets and clotting factors, which then creates bleeding, because there's no platelets to essentially stop any trauma that might have occurred, any cuts or abrasions or something, or prevent the blood from essentially leaking out of the system. Tissue ischemia will also occur, which will end up in the patient in organ failure. And then later on in the process, the activation of abnormal fibrolysis, so the body is trying to reverse itself. However, by doing that, it's going to cause further bleeding, and there's already just no platelets in the system because they're all activated and consumed. And so then the body ends up breaking down the clots, which lead to more bleeding. So it is a pretty vicious cycle. Again, it is life-threatening, and so we want to be able to treat this appropriately and fast. Some common lab values with DIC. You're going to be looking at platelet count, your PT, PTT, fibrinogen, your D-dimer. All these are going to either be elevated or decreased based off for essentially your DIC patients. Some different diagnoses for DIC: risk of fluid volume deficit because they're bleeding out, risk of impaired skin integrity, ineffective tissue perfusion because of the patient entering into a hypovolemic state, risk of injury, and so these patients will, be staying in bed. They'll more likely be in the ICU probably at this point, but we want to make sure that the patient's not going to try and get up and out of bed, and that we're educating them appropriately on all their risks. So complications. The complications come from the organs being damaged by all the micro clots. So you can have kidney injuries, you can have pulmonary embolisms, respiratory distress due to the pulmonary embolisms and the vascular and even the bleeding into the lungs. Strokes can occur, heart attacks as well. So it just depends on where all the microclots ended up and what organs being affected. You can also have ischemic bowel occur as well if all the microclots end up throughout the GI system. Interventions, you're going to want to maintain the hemodynamics of the patient, maintain intact skin, oral mucosa. They can easily start bleeding from their gums. Definitely if we're providing oral care, they can end up with bloody nose. They can have potential for risk of aspiration with heavy nosebleeds, if there's any blood that goes into the back of the throat that the patient might not be able to clear. We're also going to, be monitoring the patient very closely, vital signs, and decreasing any potential risk of bleeding. Blood transfusions is probably the most common treatment for DIC and even any type of hematological disease, so any type of anemia. So we can get the patient back up to a therapeutic level and prevent any further complications of essentially hypoxia. Sometimes blood transfusion is just a temporary support for the patient until the underlying problem is resolved. Now there could be an autoimmune disorder that's causing this, and so we might not be able to ever resolve the condition, and so these patients could be in the hospital as an outpatient maybe every week, getting a blood transfusion to help keep their levels high. So we just want to support these patients and educate them to the best of our ability, and understand and know why we're doing what we're doing. So there's different types of blood products. We have packed red blood cells, platelets, fresh frozen plasma. Albumin is sort of categorized as a blood product. We don't treat it in the hospital as like a blood product. However, it's used in hypovolemic shock quite often. And then there's also cryo that we use that has a lot of the clotting factors in it, which will also be used and administered in DIC as well. Transfusion therapy, pre-transfusion responsibility. We want to make sure it's the right patient, right time, right blood band ID. So we're verifying the patient and the blood band ID with the blood product. We're examining the blood, making sure there's no discoloration, any bubbles, cloudiness. We're checking the expiration date. And so there's a lot of triple and double checks. And with blood products, you're going to be checking also, you're going to have another nurse in the room verifying the blood product when we transfuse to make sure that, that everything is correct. So we're not mixing up the blood, because the last thing we want is a blood reaction. So transfusion responsibilities, you're going to provide patient education, assess vital signs. You're going to stay with the patient for the first 15 minutes. And you're going to start the infusion slow. After the first 15 minutes, if the patient's not complaining of any signs of reaction, then we can increase that transfusion rate. We want to make sure the patient understands to verbalize if they start having any chills, shortness of breath, hives, or itchiness, or even any back pain, definitely around the kidney areas, while they're receiving the blood product. Clients can develop several different transfusion reactions. It could be an allergic reaction. It could be a hemolytic reaction to the blood, bacterial, or even a circulatory overload if we're trying to transfuse too much blood into a patient. And that can be putting their circulatory system in overload. And so we just want to be on the lookout for any of these reactions, so we can stop the transfusion immediately and notify the appropriate people. So with the reactions, we're going to stop that transfusion. We're going to maintain a patent IV. All right. We also want to notify blood bank and the healthcare provider of the reaction, and we're going to send the blood, the IV tubing, everything that blood touched. We're going to be sending it to lab so they can run, or send it to blood bank so we can run different tests on it to see what exactly went wrong and why they ended up with a transfusion reaction. And of course, we also would definitely need to document this on the patient's chart so we can make sure that it wasn't, if it was an antibody reaction to the blood, then we might need to provide different precautions or have some different blood when administering any blood product to that patient again. All right, so that pretty much does it for this slideshow. Please review and look over that table that I posted and fill it out as you go through your readings. It will be end up being a really good study guide for you guys, either for the next exam or even for the NCLEX. And so, the stuff listed there are very common conditions of anemia and bleeding disorders, and so I want you guys to definitely be aware of them and just the basic sort of information about it.